Finals SAQ47, Rheumatoid Arthritis. A 72-year-old patient with long-standing severe rheumatoid arthritis presents for total knee replacement. A. Which joints may be affected in rheumatoid arthritis and indicate why this involvement is of relevance to anesthesia? Rheumatoid arthritis is characterized by a chronic symmetrical polyarthritis of mainly peripheral joints, especially the fingers, elbows, ankles, but also more proximal joints, such as in the shoulders, neck, knee, and hips. This is relevant to anesthesia as they may be the focus of an operation, which dictates the choice of anesthetic technique, and the involvement of any joint may make positioning for regional anesthesia problematic. Temporomandibular joint. Arthritis of this joint may impact on mouth opening and hence ease of intubation. Limited mouth opening may necessitate fiber optic intubation. Cricoarytenoid joint fixation may cause preoperative hoarseness and rarely stridor from glottic stenosis. Minimal edema may cause airway obstruction post-op. Atlantoaxial subluxation. Assess range of movement and symptoms while patient is awake. Excessive movement, such as during airway management, may cause spinal cord compression. Inquire about tingling hands or neck pain. Atlantoaxial subluxation may necessitate fiber optic intubation. Anterior type is the most common, 80%, followed by vertical, 10 to 20%, posterior, 5%, and lateral. Atlantoaxial subluxation occurs in about 25% of severe rheumatoid patients. Only a quarter will have neurological signs or symptoms, and risk factors includes duration of disease more than 8 years, glucocorticoid use, seropositivity, and nodular or erosive peripheral joint disease. Subaxial subluxation, which occurs below C2, is significant when loss of alignment is more than 2 mm. Look for this particularly if the patient has undergone previous fusion at a higher level. Relevance as per atlantoaxial subluxation. Cervical ankylosis may cause limited neck extension, leading to difficult airway. Involvement of costovertebral and costotransverse joints may lead to restrictive lung defect. Arthritis of small joints of the hand may limit ability to manage PCA. Other joint deformities may limit positioning and regional anesthesia. B. Which systemic features of rheumatoid arthritis may be elicited during pre-op assessment? Airway. Difficult airway, as mentioned in Part A. Larynx may also be obstructed by amyloid or rheumatoid nodules. Respiratory. Fibrosing alveolitis may lead to restrictive defect. The patient may have obliterative bronchiolitis, pleurisy with effusion, lung nodules, and costochondral disease leads to reduced chest wall compliance. Cardiovascular manifestations includes pericarditis and pericardial effusions. This rarely leads to tamponade. It is usually gradually restrictive, requiring pericardectomy. Rheumatoid nodules may affect any layer of the heart. It may damage valve function, cause conduction defects, and rarely cause congestive heart failure. Myocardial fibrosis, atherosclerosis, coronary artery disease, aortic incompetence, and endocarditis may occur. There is higher risk for venous thromboembolism. Systemic vasculitis may lead to arterial occlusion in various organs and Raynaud's. Rheumatoid patients have difficult IV access. Neurological manifestations includes peripheral neuropathy due to nerve entrapment such as carpal tunnel syndrome, ulna, and lateral popliteal. Mononeuritis multiplex may be due to vasculitis. Neuropathy may be due to drug treatment on top of the disease itself. Autonomic dysfunction may lead to blood pressure and heart rate lability and gastric paresis, which leads to increased risk of aspiration. Compression of nerve roots due to spinal involvement may occur especially at the cervical spine. Practice caution with positioning. Endocrine. Chronic steroid use compromises glucose tolerance. This may lead to diabetes mellitus. Consider need for perioperative replacement, immunosuppression and risk of infections, skin fragility, and care with positioning. Hematology. Normochromic normocytic anemia of chronic disease due to drug-associated myelosuppression and NSAID-associated blood loss. Iron deficiency anemia and thrombocytosis may occur. Bone marrow depression may be caused by DMARDs. Felty syndrome is splenomegaly plus neutropenia in rheumatoid arthritis, and this may be associated with anemia and thrombocytopenia. There may be low albumin levels and high fibrinogen and alpha-1 acid glycoprotein levels. Immune and infection. There is higher susceptibility to infection due to DMARDs, TNF inhibitors, and steroids. Sjogren's syndrome and resultant dry eyes put patient at risk of corneal ulceration. Cutaneous musculoskeletal. Friable skin may occur due to chronic steroid treatment. There is risk of damage with dressings for cannula or during handling. Fixed joint deformities may be present. Care with positioning. Renal. Chronic inflammation may lead to amyloidosis. Glomerulonephritis may be present. Drug treatments may lead to chronic kidney disease, which affects pharmacokinetics of drugs used perioperatively. Methotrexate may cause liver cirrhosis, which impact on drug pharmacokinetics. C. Outline the preoperative investigations that are specifically indicated in this patient and the derangements that each may show. Full blood count may show neutropenia, anemia, and thrombocytopenia. Elective surgery should not be continued if the patient is neutropenic. Correct anemia before major surgery. Thrombocytopenia may preclude regional anesthesia. Renal function tests may show high urea and creatinine levels and low GFR. Liver function tests may show elevated transaminase levels and ALP in active disease. Methotrexate is a common cause for cirrhosis. ECG may show conduction disorders and LVH. Chest X-ray is indicated if there are respiratory symptoms and may reveal pleural effusions, infection, fibrotic lung disease, and nodules. Lung function tests if respiratory symptoms are present. Restrictive pattern is usual. Echocardiogram is warranted if murmur is noted and if there are heart failure symptoms. Regurgitant valves may be due to nodules or pericardial fibrosis. 24-hour ECG tape if patient has palpitations. Arrhythmias may be due to nodulosis of conduction pathways. Nasal endoscopy and ENT assessment if there is pre-op hoarseness or other indicator of airway limitation. Flexion extension X-rays or MRI of cervical spine if patient has pain or neurological symptoms or neck extension or flexion. Rheumatologist or spinal surgeon involvement is recommended in patients with neurological symptoms or signs and in those with persistent neck pain. Pre-op cervical spine flexion extension views are controversial. Stabilization surgery may be necessary before elective surgery. Specialist radiological advice should be sought. Additional information. Examiner's report. Answers given by most candidates reveal a poor understanding of the important factors in the pre-op assessment of these patients. Many scripts demonstrated a medical student level of appreciation of the topic, such as writing the neck in response to the first question on joints affected by the disease. A scattergun approach was taken by weaker candidates who wrote down all pre-op investigations that they could recall, despite the question asking for specific examples. Every time one writes an investigation, qualify why in this particular patient. Every time one states that one would ask something in history or examine some aspect of the patient, state why in the particular circumstance. Every time one says that one would do a type of monitoring, say why in this particular patient. Rheumatoid arthritis is a chronic systemic inflammatory disorder, mainly involving synovial joints but with extra-articular effects. These have been discussed in Part A and Part B. Overall prevalence in the UK is 1.5 per 100,000 in males and 3.6 per 100,000 in females, peak incidence at the 7th decade. It also affects children as Still's disease. There is higher than average mortality due to both the disease itself and presence of concurrent disorders. Drugs in the perioperative period. Steroids. Steroid use should be minimized prior to surgery. Steroid supplementation may be indicated, especially for patients who take prednisolone equivalent of 5 mg or more for 4 weeks or longer. NSAIDs. Continue NSAIDs to enable early mobilization. Stop if post-op bleeding is a potential problem, hypotension or deterioration in renal function. DMARDs. This includes gold, penicillamine, methotrexate, azathioprine, cyclophosphamide, cyclosporine, leflunomide, and sulfasalazine. Continue DMARDs as little evidence that omission reduces post-op complications. If leukopenic or for high-risk procedures, consult rheumatologist. Biological DMARDs includes TNF inhibitors such as etanercept, infliximab, adalimumab, and certolizumab, IL-1 inhibitors such as anakinra, IL-6 inhibitors such as tocilizumab, and B-cell inhibitors such as rituximab. The potential increased risk of post-op infection needs to be balanced against the risk of perioperative flare. Consider ceasing at least one dosing interval prior to surgery or longer for higher-risk procedures. Specifically, rituximab and tocilizumab should ideally be stopped 3 to 6 months and 4 weeks respectively prior to elective surgery. Recommends around 14 days post-op if uncomplicated post-op cause. Intra-op considerations in rheumatoid arthritis. On top of those discussed in question A and B, consider regional anesthesia, which may be technically difficult, if possible, to minimize the need for airway instrumentation. Unless it is certain that the cervical spine is stable, all rheumatoid patients should be treated as if they have an unstable spine, given that the majority of patients with atlantoaxial subluxation are asymptomatic. Restriction of cervical spine motion is necessary during airway manipulation when the patient is unconscious. If intubation is necessary, consider video laryngoscopy or fiber optic intubation if difficulties are anticipated, and a smaller ETT in the setting of cricoarytenoid disease. Blood conservation techniques in anemic patients. Ensure careful positioning, padding and protection of vulnerable areas. Note comfortable position before induction and try to maintain this during surgery. Avoid hypothermia, which increases risk of wound infection. Post-op considerations. On top of those discussed in question A and B, monitor for post-op extubation edema from cricoarytenitis, adequate pain control and physiotherapy for early mobilization, DVT prophylaxis until the patient is fully mobile, maintain fluid intake and monitor renal function. With regards to recommended doses for intra and post-op steroid cover in adults receiving adrenal suppressive doses of steroids, steroid replacement is recommended for patients taking prednisolone equivalent 5 mg or more for 4 weeks or longer. This table has been sourced from Woodcock T. et al.'s article in 2020, Guidelines for Management of Glucocorticoids During Perioperative Period. For major surgery, intraoperative steroid replacement, recommended regime is hydrocortisone 100 mg IV at induction, followed by immediate initiation of IVI hydrocortisone at 200 mg over 24 hours. Alternatively, dexamethasone 6 to 8 mg IV. If used, this will suffice for 24 hours. The same dose regime is applied for body surface and intermediate surgery as intraoperative steroid replacement. For post-op steroid replacement in major surgery, recommended regime is IVI hydrocortisone 100 mg over 24 hours while new by mouth, or IV hydrocortisone 50 mg 6 hourly by IM injection. Resume enteral glucocorticoid at pre-surgical therapeutic dose if recovery is uncomplicated. Otherwise, continue double oral dose for up to a week. For body surface and intermediate surgery, post-op steroid replacement, double regular glucocorticoid dose for 48 hours, then continue usual treatment dose if uncomplicated. For bowel procedures requiring laxative or enema, continue normal glucocorticoid dose, equivalent IV dose if prolonged new by mouth, treat as per primary adrenal insufficiency if concerned about HPA axis dysfunction and risk of adrenal insufficiency. For labor and vaginal delivery, administer IV hydrocortisone 100 mg IV at the onset of labor, followed by immediate initiation of continuous infusion of hydrocortisone 200 mg over 24 hours. Alternatively, provide IM hydrocortisone 100 mg followed by 50 mg 6 hourly via IM route. Recommendations for caesarean section is as for major surgery. Prednisolone 5 mg is equivalent to 20 mg of hydrocortisone, 4 mg of methylprednisolone, 0.75 mg of dexamethasone, 0.75 mg of betamethasone, 25 mg of cortisone acetate, 4 mg of triamcinolone, and 6 mg of deflazacort. Thank you.